Evening, Oscar.
Large thing of wafery chocolate thing. That's my sort of snack for this evening's presentation.
Excellent. I've got a cup of black coffee.
At this hour, Liz.
Read the ringing endorsement of the.
We should have popcorn, obviously.
Yeah.
In order to get the only room in the house where I'm not going to get disturbed by either the dog or children, I've come into the room that's got the worst dark light balance. I'm just looking at this. This is hopeless. Anyway, I think we might make a start. So welcome everyone. Absolutely delighted that you are giving up your free time on a Monday evening to join us. Tonight's session will run in the following order if you haven't been to one of these. First of all, we have a fantastic talk on his research by Dr. Oliver. Then there's an opportunity to ask him any questions that you would like, and then I will get them to introduce themselves in detail later, but we've been joined by some very keen Homerton College, University of Cambridge medical students who, along with myself, will answer any questions you've got about applying to university, personal statements, interviews, etc. So you might want to think of any of those that you've got as you listen to the talk. So I will start by introducing Dr. Oliver, who is currently working for a PhD at the Wellcome Sanger Institute just outside Cambridge. Prior to this, he was an academic histopathology registrar for 2.5-3 years first. But originally, before joining us in East Anglia, he did his medical training in Nottingham. So thank you very much, Tolly, and over to you.
Thanks, Liz. Okay, so welcome everyone. As I said, thank you for coming to listen to me ramble on for an hour. I should preface by saying I've just come back from a run, so if I appear red-faced, it is still that I haven't gone back to my normal facial colour, so apologies for that. So I'm going to talk a bit about the research I've been doing over the last 3 and a bit years, and hopefully that will provoke some thoughts and questions that we can discuss afterwards. Liz has already kindly given a good summary of my medical career today. I'm hoping if you've been to some of these other talks that other people have shared a bit about how they got to where they were, so you can appreciate the sort of all the different things that you could potentially do within medicine. So I'm not going to repeat a lot of what Liz has said already, but just to highlight a few things that you maybe not appreciated before or thought of within medicine. So one thing I was able to do at medical school is to go on an exchange program to Oslo Medical School for a semester for 6 months. And I found that incredibly enriching from a medical perspective. The way they organised their teaching is very different to the way it was done in Nottingham. And also sort of on a personal perspective to sort of see how another healthcare systems run, meet people from an international exchange cohort. And I'm going to the wedding of one of my friends I made at that exchange this summer. So if you can go on an exchange whilst at medical school, I'd highly recommend it. The other thing I suppose I sort of did in my spare time was pick up a bit of coding and machine learning. It's very difficult to do when you get into the clinical, start getting the sharp end of the medical school training and afterwards in your clinical training. But just the sort of, these are things that I've actually found have come back to be incredibly useful in my research. So these sort of other skills that you may not think of as doctors picking up actually can become incredibly useful if you start to think about, you know, the diverse careers you can do within medicine. I did an intercalated degree. You don't have to do one at many medical schools, but if you're thinking about doing a blended clinical or an academic career later on, it was something that I would recommend you doing. Okay, so to the topic at hand then. So just give a bit of a very, very, very brief history of cancer in a single slide. This is an entity that has been with us since, as long as humans have been around. We've been afflicted by cancer. And I discovered this from the books I'll suggest at the end of this talk, but we've been describing cancer since about 3000 BC. The ancient Egyptians described what can only be these breast cancers that they were treating by cauterization, so basically just trying to burn it off, which is incredibly gruesome, as you can imagine. And their conclusion after trying this was that there was no treatment. And actually for thousands of years afterwards, there was no advance whatsoever. And then we start to get things like radiotherapy come along, and obviously you might have accidentally been exposed to radiotherapy to begin with and seen the effects on normal skin, and then it was deployed for skin ailments just towards the end of the 19th century. And we then had 50 years later, we started to get chemotherapy. So relying on things that you might inject or a tablet you might swallow to get an agent around the body that you would hope would preferentially target the cancer cells over normal cells. And there's sort of the stories of this where there was mustard gas accidentally released by a ship in the Mediterranean that was sinking during World War II. And the poor sailors that were in the water when the mustard gas hit it, many of whom died when they looked at the bodies after they died. They found that a lot of the cells in the bone marrow, where the blood cells are made, had been wiped out, and that's because this agent had preferentially targeted the dividing cells that make the blood, and that sort of gave a clue as to the mechanism of action, as it were, for this agent, which was adopted into a chemotherapy agent. Okay, so this is a very, very simplified version of it, but I think it's just good to recap what exactly we mean by cancer. Really, it comes down to a loss of control of the growth, the cell turnover, as it were, at a given site in the body. So if you imagine this being in your gut, and then once it's lost control locally, it then acquires the ability to invade locally and then to a distant site. And you might have heard of the term metastasis before, where really it just means that this growth has gone beyond its local region, its site of origin, to take hold elsewhere. And so in the example here, we've got some cells in your gut here, and then over time, due to maybe just cell divisions over time, or because of exposure to certain things in the environment, and certainly for the gut, things like red meat might be a more pertinent one. Mutations are required, and eventually one of those mutations hits the genome in such a way that it occurs at a spot where it suddenly makes that cell start to divide more rapidly than it would normally do. I'll come back to the questions at the end. Sorry, I just realized I can see them popping up. And that cell starts to grow, have an advantage, and start to grow out and populate the local region. And then eventually within those cells that already have the first mutation, it might get a second mutation then. And depending on the cancer type, there'll be different numbers of mutations at different sites that are needed. And eventually it grows out, and maybe that second mutation allows it to invade beyond this normal lining here into the surrounding tissue, and then we consider it to be cancer. It's worth saying that overwhelmingly the mutations that are acquired is basically a normal process. We all have mutations that are developing in our bodies all the time, and overwhelmingly these end up at parts of the genome, parts of our DNA, our building blocks of life, that have no downstream consequence, and they're sitting there. There's no impact on the way to cancer. It's these few that hit these critical spots, as it were. And this is what we call a traditional two hit. You've got mutation 1, then mutation 2 that allows the cancer. I'm not going to go into the details of this. I think it's probably a bit beyond the scope of today, but I just wanted to give you some sense of this sort of stepwise progression within a particular cell type. So here we have, looking down the microscope at a bit of someone's bowel. These are what we call these crypts, these dips in from the surface here. So the food would be going through here, or this is turned to feces at this point. And we have these cells here that start off as little stem cells here. They divide, mature, and migrate up to the top like little escalators. And if they start requiring mutations in genes, so genes are parts of the genome that start to produce proteins, and the proteins allow us to communicate between cells, the things that make up our muscles and so on. One of these genes, if this is mutated here, then it starts to become irregular, the cells in these crypts. And over time, with further mutations in further genes, you start to get a loss from these nice little test tubes to becoming increasingly disordered until eventually it invades locally. So to begin with, it's what we call in situ, and that's just Latin, within the place where, within its site of origin, as it were, and you consider that to be sort of precancerous. And then when it invades and then it can spread to other sites, this metastasis term, then we consider it to be cancer. And both terms together we call neoplasia, which just means new plasia, I guess, a new growth. This is how it happens in adult, as a sort of a traditional model of how most cancers or many cancers develop in adults. And this is our model from the 1980s, and it more or less can be applied to many adult cancers. Now we have to think, I'm going to talk about children's cancers, and you think, well, all those factors that we saw coming into play for adult cancers, children have often had a much shorter period of time in which to develop there. So would they necessarily be driven by the same processes? And the answer to that is no, and we'll look into that shortly. The thing that sort of adds context to all of this, and I think perhaps by many of you finishing medical school will become, a really routine part of healthcare, is this technology we now call, there's a sort of an umbrella term now of next generation sequencing. And what this is ways that allows us to sequence bits of our DNA or RNA very large scale and very quickly to get answers that previously would have taken an unspeakably long period of time. And really, just to give you some to help you get orientation of this plot, here we have the cost of this method per unit of our DNA produced, and you can see that the cost is going down precipitously. And then you've got the output of one of these machines doing it, these sequencing machines per week, and that's this green line going up. So some of you may have heard of the Human Genome Project. So you've got a project in 2001 that cost about $3 billion to sequence the first human genome. That was a 15-year effort. And in contrast, even as back in 2014, we're able to sequence about 45 human genomes a day on a single machine for the cost of about $1,000 each. So you can see how the cost of this has come down, and the output has gone up, and we can now use this to potentially really change the way that we treat patients. So again, not going into the details of this technology in great detail, but I just want you to think of the mutations that are required over a lifetime, because many of these are, don't have to be the drivers. They can be sort of passenger mutations. They serve as a sort of black box of what's happened in the body prior to you taking that piece of tissue. We take our DNA, we break it up into pieces, we put those pieces on a membrane, we amplify up them on the membrane, and then we start to look at the different, the sort of 4 different bits that are used in different combinations to basically make the entirety of our genome, the nucleotides, and we get that readout, and that tells us this story of the human body right from the sequencing data. So using the data and a few mathematical principles, we can start to time when critical changes occurred during a person's life. Okay, so I've mentioned already that we have a good idea for adult cancers, and we have some sense that maybe something's a bit different in childhood cancers, but can we see that in data? Just so if we collect a lot of cancer data from adults and a lot of cancer data from children, do we start to see anything that backs up that suspicion? So indeed we do. So this is a graph of the incidence of cancers binned by age. So obviously with kids here and adults up to the most elderly and 90 and over here, and the relative registration of cancers per 100,000 people. And you can see that overwhelmingly in men and women that cancers tend to occur in older individuals, which makes sense, but there are still some that occur down here, but it's obviously much less common amongst children. I mean, it's that being said, though, that although it's not very common amongst children, I mean, thankfully, there aren't many reasons why a child might pass away, but it is still the most common cause amongst children 1 to 15 as a cause of death. So within that, it's worth seeing in that context, as it were. The other thing is that because obviously because children's cancers are mercifully not very common, historically what's happened is that treatments have been found in adult cancers, and they've been sort of retrofitted to children's cancers because just the numbers needed to statistically, detect the improvement that treatment offers over perhaps the previously existing treatment. But it also makes sort of developing new ones specific for their cancers more challenging. So not only do they occur less frequently, but the types of cancers that children tend to get are different. So these are just lists of different types of cancers that children get, age 0 to 14, and this is a blood cancer, this is brain, this is another blood one. Soft tissue might be sort of muscle and fat, for example. And just to see here, this one called epithelium here is this tiny sliver here, which includes things like breast or the bowel that we spoke about before. This brown sliver here is effectively almost all the cancers, bar some blood ones, that are seen in adults. So whereas this basically for the same pie chart for adults, males and females, this would be overwhelmingly brown. So they have different types of cancers. Children tend to get a lot more of blood, brain, and soft tissue compared to adults. So they get different cancers. So there's different types. They tend to occur earlier. And I mean, luckily, they tend to have a better prognosis. That's definitely not always the case. But if you are to take all cancers, and this one's now from age 0 to 24, we now have the proportion of patients surviving. This is the time out from their diagnosis for children, and this is for adults. And you can see this line being slightly higher here than it is, for example, amongst the cancers of adults. There's still a subset that, sort of regardless of treatment, are very resistant and have a very poor prognosis, and those are often what a lot of the research is now focused on, trying to identify maybe before treatment at all, or finding a sort of second or third line therapies for. But overall, children tend to have a better prognosis than adult patients. I mentioned before that a lot of these mutations are just a normal part of cells as a consequence of cell division and the things in their environment. And that's the same for normal cells and in cancer, where most mutations are have no functional consequence. But you can see, so just to orientate you to this plot, what we have here is a metric measuring basically the number of mutations in a cancer, and these are different types of cancers. And the different types of cancers are split into the ones that you see in children and the ones that you find in adults. And the higher the dot is up here, the higher for that particular cancer, the higher the number of mutations that you see within that cancer. Now, this is not a normal scale, it's what we call a log scale. So you can see each of these going up by factors of 10 each time. And you can see that the children's cancers tend to be lower down this scale than the adult cancers, which tend to be higher up here. They tend to have a higher mutation rate in adult cancers. In fact, the number of drivers that they often tend to have is greater, as well as a sort of an aside there. The other thing worth mentioning is that for child cancer, about 10% of them are due to something they've inherited or they've developed in their first cell that propagates throughout their body, what we call a germline mutation, and that rate is much, much lower in adults. So children tend to have, if they do have cancers, are more likely to have had it as they've been predisposed to it than adults. Okay, so why is it that they're getting different cancers? How is it that they are, what's going on in their early development that may indicate that they're a different kettle of fish, as it were, compared to adult cancers? So I'll use an example that's from my the lab. It was when I very first joined the institute. What we have here is the very first cell that makes any of us, the zygote here. and from this cell makes all the other cells in our body. A few of these cells will go on to give rise to all the cells of the blood, and a few of these cells will give rise to the kidney. And now in children with this kind of kidney cancer, which is called a Wilms tumor, we find that not only the cancer doesn't just sort of emerge out of a totally normal kidney, but instead there's a collection of cells that become abnormal very early on in development, and then they start to occupy a large part of the kidney as well. Now it looks to the naked eye, and when I look down a microscope as a pathologist, like normal kidney, but actually there's been an underlying change which gives those cells a slight advantage in growth, but still within that, very early on, there's a further deviation of the tumor. Now, if this happens super early on, you can get really unfortunate cases where a child ends up with tumors occurring in both kidneys because they've had this sort of, had this go wrong in the original cluster of cells giving rise to both kidneys, and some of those cells have been carried across to both kidneys. And this is not the only sort of example of something like this going on, but already we can see that in these poor children with this tumor, they may well have had this from very early on, whilst in their mother's womb. And it's not just for kidney. This is a very aggressive brain tumor, for example, and this is driven by a different kind of mutation to just sort of occurring as a replacement of one letter from this alphabet that I've shown some letters from with another one, but large-scale changes of large chunks of DNA. So maybe from biology class, you might remember chromosomes having a small arm, a P, and a long arm, Q. And in this particular tumor, having two copies of the long arm attached to each other, which we'd call an isochromosome, is considered a sort of triggering event early on. And by looking at the mutations that are occurring and on this region here, we can actually confidently say in these patients that this will have occurred whilst the baby's still in the womb and their brain is still developing. So this again is something that's gone wrong very early on in development. It's not guaranteed to, we can't take that as a given, however, that it's just a clear division between, okay, so cancers in children started when they're in the womb, and cancers in adults only start, much later on in life. So this is an example in blood, and blood seems to act in a slightly different way to these other things that I've shown before. I'll just check some questions and just check if there's anything conceptually I need to touch on. I need less. Okay, I can come to those at the end. Each of these dots represents a cell within our blood. So if you had a blood sample taken, all the cells were split apart, and you were able to get a good copy of the DNA in all of them. Each of these dots would represent the DNA in that cell. And then you can say, again, because they're thinking back to our black box from before, how many of the mutations in a given cell are shared with another cell, and the more mutations that are shared between them means that they more recently in time came from one cell that gave rise to both of them. And you can use this to time back to key events that are going on. And these are key mutations that are considered driving mutations in certain blood cancers. And in this blood cancer, which was diagnosed, you can see the diagnosis was in much later. So you can see diagnosed at 21 and 31 here. You can actually time the time that the driver mutation, the one that gives it that kind of extra push to grow more and outcompete other cells, to about 6 weeks into after the baby started developing in the womb. So these events could be started very early on in development, even in some adults too, even some adult cancers. But blood is sort of perhaps a different, as I say, different kettle of fish. Okay. Now, if we put this all together from what we've spoken about already, we can see that at a very basic level, there are two broad ways you can think about the path to cancer occurring. You've got, I said, the very first cell that makes all the rest of the cells in our body here. It then develops into more mature cells of, there might be skin or gut or bits of our lung or what have you. But as it's going towards that mature cell that we think of as having when we're, as you or I have now, at some point it gets blocked from continuing to becoming a mature cell. And as it gets blocked there, it might be blocked because it's had a mutation beforehand, or it might be there's some sort of other reason for a block, and then it acquires a mutation. It then starts to transform into cancer. And this is the case, as I said, for childhood cancers and many blood cancers and some soft tissue and bone ones of younger adults too. This is in contrast to that, if you think back to that schematic of the gut I showed you before, where you start off with a mature cell. In this case, if you remember the test tubes in the bowel, acquiring a mutation, several mutations that are critical positions in the DNA, and then ultimately becoming invasive and becoming cancer. And this is the traditional one of adults. So the ones that we get in our bowel, lung, breast, prostate, the esophagus, or the gullet, and stomach, and so on. So you think, okay, well, it's all well and good knowing that they might be different, but what can we do with this information? The hope is that if the reason that it's sort of become cancerous is it's got trapped in an immature state, to overly simplify it, but broadly speaking, would it be possible to take that immature cell and convince it to become mature and remind it, where it's supposed to be going? So there are different tags on top of our DNA, and we call the epigenome, with these little tags on it. And if we can start to manipulate those, can we convince that cancer cell to start becoming or behaving more like a mature cell? But clearly, in order to get to this mature state, we need to know what is the normal path. We need to give the cancer, as it were, a map or some directions so it knows where to go. And really, that's what, and that's all a lot of research that we're doing in my group and elsewhere is trying to establish what is really the difference here between first of all, what's the sort of the immature cell the cancer comes from, and then once you've got a cancer cell, what sort of changes in the cell would be necessary to make it the more mature cell? Because if you can make it more mature, it doesn't divide as quickly, it doesn't spread, and behaves itself. And we would call this what we call differentiation therapy. So differentiation is really just going from one cell state to another cell state through a series of cellular changes. And the reason we're looking to do this, because obviously most children mercifully have a good outcome from their cancer if they get it, is that the side effects of having these agents long term can be really quite profound. So in order to attack the cancer cells, a lot of them rely on attacking all rapidly dividing cells. And so clearly that might have other consequences. So the injuries it does to the DNA of cancer cells, it might also do some damage to normal cells with a risk of subsequent cancers later in life. You've got things like heart disease, or it might attack the germ cells, which are found in the testicles or the ovaries, and that might make the child, as they grow up, become infertile. Them have lung scarring or kidney damage from these agents. So it's important to see if we can find much less toxic ways of treating them just as effectively. And one example of this in a kind of blood cancer, we have this agent here, which is one of these differentiation therapies, which induces the blood cancer to become more mature. And then we've got some standard chemotherapy here. And this is, and more patients are without their cancer. That's what this means, this disease-free survival. More patients are without their cancer further down the line here, from diagnosis onwards, with this treatment than the standard chemotherapy. So not only might it avoid some of the side effects that you get from these treatments, it also actually appears to have a better effect than the old standard regimen that was there before. So, I mean, I've long had a great sort of passion in and interest in cancer, and really these were two of the books that started it off for me, and I think they are. I mean, I consider to be recommended reading, and that certainly if it's sort of before medical school, during medical school. I mean, I read one of them afterwards. But this book in particular by Siddhartha Mukherjee, a physician from the US, on the history of cancer, was a really compelling reading, and it is pitched not at a medical audience. So I'm hoping it would be, a general readership would find it of great interest, and would help us understand how it helped me understand how pediatric and adult cancers developed and their treatments over the years. And then for a more kind of personal story, I enjoy reading the Immortal Life of Henrietta Lacks, which considers the more ethical things around cancer research. It's more of a personal narrative perhaps than the other book, but thinking about the ethical dilemmas that cancer researchers face. Obviously, for personal statements, reading such as this might give you some material, as it were, or things to ponder. So thank you for listening. I can see I've got some questions already, but if anyone wants to ask anything now, please put it in the chat, and I'll start making my way through it. Unless, Liz, you want to ask the questions, or how do you want to do it?
No, I'm very happy for you to answer them. I will be very honest at this point, and I think it's good to highlight this. Thank you very much for typing them in the chat, because I've been Googling the answers to a couple of them, because I will confess I didn't know them. So, but I am now fully informed, because in the time that Tolly's been doing this talk, I've read 2 papers which will allow me to answer some of these, but we'll get going on them. So first question, are there any particular parts of the body where you are more likely to have tumours?
The answer to that is yes. So in the thinking, but if we take all cancers from children and adults and all together, we can certainly see there are cancer types that are seen much more commonly than others. There are several reasons why this might be the case. I mean, typically they tend to be on the bits of our body that interact with our environment. So skin, the gut from the things we eat, for example, lung from the things we breathe. And that's partly because of the things in our environment that can maybe increase our risk of cancer. So smoking for lung cancer, for example, but also the kind of cells there have a higher level of cell turnover. So if you have a high level of cell turnover, every cell division, and there's an opportunity for more mutations to occur. So the answer to that is yes.
It's also how common various sites are, or otherwise, also very much does depend on the specific environment. So if you look at the incidence of melanoma skin cancer, for example, it is much more common in Australia than it is in the UK. So that you can see the effect of the various different environments from that perspective. Okay, so the next question, in an article, it was mentioned that from the year 1998 to 2018, the cause of childhood leukemia increased 110%, and the death rate also increased from 21,600 to 24,370. What is the main cause of this abrupt increase in the rate? Why are the developing technologies can't restrict this rise from olden days to modern era? So I went and had a look at this, because this I thought was quite interesting. And childhood leukemia is not a sort of a homogeneous, identical entity. There are a number of different separate disorders within that. And I think the first thing I would say is that the general outcome from childhood leukemia is more favourable than on the adult side. But there was indeed an increase in the incidence of these tumours over time. Now, you have to look quite carefully at differences in the incidence of tumours, because if you're comparing an era where there wasn't full reporting of tumours to cancer registries to now, where pretty much every tumour is accurately reported to a cancer registry, for example, in the UK or the US, what you are sometimes picking up when you pick up an increase over time is that you're actually picking up better recording and identification of cases. So the only way that we know what the overall rate of cancer in a country is if every single case of cancer is registered. So certainly in the last 20 years or so in the UK, we've got very, very good at registering these cases. But if you go back slightly more historically than that, some of your change in incidence relates to how accurately it is recorded. But even allowing for that, it is indeed described that in certain countries there has been an increase in the incidence of leukemia. And one of the papers that I just found and was having a read of about this was based in the US. And what it was showing was that actually that the rate was increasing in certain populations, but not others. And that may tie into various different exposures to environmental influences, for example. Why specifically childhood leukemia increases is a bit of a difficult question, because and I'd be interested in Tolly's thoughts on this. I'm not sure that, bar a few very specific examples, such as the inheritance of certain germline mutations, for example, Fanconi anemia genes, and certain environmental influences that we know are very definitely associated with childhood leukemia, like exposure to ionizing radiation. I'm not sure we have a really very, very clear handle on the causes of childhood leukemia. You'll see various interesting theories, such as the infection related, the germ theory and things like this. But it's difficult, I think, when we don't fully understand the cause, to explain why there might have been an increase. My impression as someone who reports biopsies in leukemia is that actually the outcomes are generally very, very good in childhood. And in the last 3 or 4 years, the drugs and treatments that we have in our arsenal against childhood leukemia mean that more and more options are in play when disease recurs. So you may have heard of CAR T cells, which are engineered T cells, which engineered lymphocytes, which you can give back to the patient after having taken them and engineered them in vitro. And there are a number of other drugs, again, that we're using. So I think I haven't really answered your question very fully, but I don't actually think there's a specific answer, particularly to the increase in cases. Tolly, any thoughts?
I was once asked to do a presentation on pediatric leukemia, actually, when I was in Oslo, and I remember reading stuff on this at this point, and I'm not my research isn't really into pediatric blood cancers. The prevailing thing I thought at the time was that germ theory, that we live in an environment now where these our early interactions with different bugs in the environment are so important in conditioning our immune system. And if you have a restricted number of them, or a particular exposure, maybe just to a particular few that are really popular within modern society, that in some way skews the way that it's worth saying, a very, very small number of children, their blood cells develop. But there may be something more to that, but I'm not an authority on it.
Okay, why are brain tumours more common in children than adults? I don't think they are. I think the proportion of children's tumours that are brain tumours is higher than in adults, but the overall rates in adults are about 4 or 5 times more than they are in children. And the range of brain tumours that children get are very different. So children tend to get quite embryonal, i.e. primitive tumours. So as a proportion of all tumours, it's higher, but that's because children don't get as many tumours as adults, if that makes sense.
Yeah, sorry, that was maybe a bit misleading. In the pie charts, it was a breakdown of all their cancers rather than saying that they necessarily get any more. Yeah.
Why do children need fewer cell mutations to develop cancer than adults?
So for a cancer to occur there's no sort of hard rules here, as it were, but for a cancer to occur within a child, it tends to occur within a developing tissue that's immature, relying on pathways that you wouldn't usually see active once the adult tissue has been laid down. And for whatever reason, these pathways can be dysregulated quite severely by single changes at very, very, very critical points. And so what you then tend to see are cancers that don't have very many overall mutations, but one of those mutations has happened to land in a very crucial spot, which has completely derailed the normal development. Because development is this very carefully orchestrated process of internal changes and subtle concentrations of different proteins interacting with external environments too. So it has to be this very, very carefully orchestrated process to make sure that, you know, cell A gets to location B in a timely fashion. So, I mean, in adults, you actually don't need lots and lots of mutations. It's just sort of, it just so happens that with enough mutations, enough of them might actually by chance end up at the right place, as it were. So I think it's based on the pathways that these cells need to live and thrive effectively. It's a bit harder maybe to dysregulate many adult epithelial cells from their normal path than it is for a very vulnerable developing child cell. But I don't know if, Liz, you have anything else to say there?
I think the other thing that I always just think about when comparing adult and childhood cancer is to remember that in a number of adult tumours, one of the things that happens in tumour development is for the phenotype of the cells to revert to a more childhood or fetal phenotype. We have these things called oncofetal proteins. So actually particularly the fetal state is much more permissive of development, and therefore you get this reversion in phenotype. So you know, it may reflect something alongside that as well, I think. Oh, here's a good one for you, Tolly. So how were these driver mutations initially tracked?
I mean, I presume I guess that they're just discovered. Right. I mean, there's actually many different ways of doing it, and these days it's done in a reasonably dry mathematical way, whereas it might have been a much more interesting kind of old-fashioned wet lab experiment back in the day. So the way that we would do it here, you would take 1,000 of a particular kind of tumor, you would sequence it, you would characterize all the mutations in it, and then you say, based on the length of my DNA and the number of mutations I have, how am I seeing more mutations in this part of the genome than by chance? And you can kind of do some maths to calculate that. And mutations which are giving cells an advantage, be that they're causing it to divide quicker, or they're breaking down some of the mechanisms that stop it dividing, start to have more of these mutations than you'd expect to find. So we'd statistically demonstrate it that way. In the old-fashioned way, you might find a gene of interest in a model, and then you might find a way to alter it and observe the changes in behavior. And it might be, for example, then some cells within a mouse, or one of the first ones was with a chicken, with a kind of chicken virus that made mutations in one of its soft tissues to cause a sarcoma, and observe it there. So it's much less exciting as a narrative today, but we do it in a slightly different way to how we used to do it.
Okay, an excellent question, kind of cutting to the center of carcinogenesis. Why does the absence of apoptosis lead to cancer?
So you can think of, in a healthy adult tissue, to keep a consistent number of cells, you have to have a reasonably equal amount of cell division versus cell death, an equal amount in and an equal amount out. If you start to reduce the ability of cells to die, as it were, I mean by apoptosis is controlled cell death, you suddenly start to have this skew towards an increasing number of cells. And if that occurs in concert with other mutations that allow the cells to perhaps even develop even quicker, then clearly you're going to get that loss of control of growth. Because remember, cancer is sort of first and foremost is a loss of control of cellular growth, and part of growth is the process of death. And if it can't die, then cells are on that path to immortality, and that immortalization is part of the cancer process.
Are blood cancers affected by the type of blood you have? So I think if you're referring here to ABO type blood groups, I don't think that they are.
Not to my knowledge. There are certain other mutations in the blood which will affect the type of blood cancer that you get. I'm not sure about whether blood type has any impact on it at all. Not to my knowledge, but I'm not a blood expert.
What is the future of dealing with emotional, psychological developments, considering the effects of cancer in pediatrics? So that's an excellent question. And I think, we focus scientifically, we focus very much on, what are the causes of cancer? What are the most effective ways that we can treat it? But actually, this is something that our clinical colleagues focus very heavily on during the course and after treatment. And all paediatric oncology, i.e. children's cancer treatment units, have a psychology team attached to them, as well as a sort of educational support team, etc. And certainly, if you're interested to see how this might work in practice, if you Google Brainbow, that's the Cambridge pathway that has been specifically designed and set up with keeping the children with brain tumours right at the centre of the focus. It sets up what we call a multidisciplinary, i.e. professionals from all different disciplines coming together to offer families and the child support, rehabilitation. And that's not just sort of focused around physical aspects, but it's also associated around educational, emotional, etc. And we mustn't forget the financial. So whether you are a family with a child with cancer or whether you are an adult with cancer, there is a financial impact on having cancer and needing therapy. So this is something that Macmillan, for example, are very, very helpful with. And most hospitals have what's called a Maggie's Cancer Centre, where you can go and you can seek advice about what benefits you might be entitled to, what support you would be entitled to. For example, if you're coming to hospital every day for treatment, there's a cost for petrol for getting there, there's a cost for parking, etc. So that's a really good question, very holistic. Whoever asked that, I think that was excellent. Can parents' lifestyle during pregnancy increase the chance of children's cancer? I think, we know that there are various factors that are important in the development of cancer. I think it's very, at the extreme end of the spectrum. If you are interested in learning about this sort of thing, then looking up a lot of the scientific data that came out of the Chernobyl disaster gives you a very clear picture about the development of different types of thyroid tumours in children who are exposed in utero and children who are exposed after they were born to the radioactive iodine. So I think, it's quite, something ping there, it's quite difficult to answer that more specifically, Tolly.
I just add to that to my understanding is that sometimes these tumours can emerge so early that the child is born with them, and for some parents there can be some that want to know that question of, is this my fault? And overwhelmingly, so outside of these Chernobyl instance, although I can't really blame the people who are in Chernobyl at the time, but the answer is no. There seems to be there's a series of unfortunate slips in the developmental mechanisms that have allowed it to happen, but it's you can see parents do have this concern, but they should be usually reassured that this is this isn't their fault or anything that they've done as such.
I think that's something that the paediatric oncologists do right at the start of treatment, is make it very clear to the parent and the child that that is the case. Okay, I will have to admit that this is not something I know about. Do you believe that artificial hypertumours may be a possible treatment in the future?
I've never heard of the term hypertumor, so it makes it difficult for me to speculate on that. I mean, certainly artificial cellular engineering is already becoming a part of treatment, and as Liz mentioned already, engineering the patient's own cells, own lymphocytes to attack cancer cells is already here, and engineering of other parts of sort of the immune response, for example, creating antibodies to attack certain to help attack certain tumors and so on, or rather alter the way your own immune system interacts with the tumor, for example. Those kind of things are already a thing, but I'm afraid I've not heard that term before, so I can't really comment on that.
And I think, there are also various studies going on at the moment about individualized tumor vaccines. So some of the tumor is used in the lab to generate a vaccine specific to that patient's tumour. I don't think to date the results on that are brilliant in the various different tumour types that it has been tried on. The other thing that I think might be somewhere where this field goes in the near future is the idea of growing people's individualized tumour in the lab. So you can use the laboratory grown tumour to test whether the tumour is going to be responsive to certain therapies. Because one of the models that we work off at the moment is we try a standard treatment based on published evidence, and we give it a number of weeks, months to work, and then we test, and then we rescan the patient to see whether it's worked or not. And if it hasn't, we then try another one. And so if it takes the third or fourth line for someone's tumour to respond, you've gone through quite a lot of treatment with side effects before you get a response. Whereas if you could test in the lab if something was going to respond early on, then you can actually dial back. And this is the idea of personalising therapy. So do you think there will be a cure for cancer in the future based on current technological and research advances?
I mean, for many tumours now, there is a cure. As a kind of the reality is there's not going to be a one size fits all for all tumours. There's been more progress made with some tumours than others. So bowel cancer, for example, has had much further advances than the ones of the pancreas, for example, or the ovary, maybe. But I mean, I based on the current technology that we have, I think we could do better than we are currently doing at managing lots of cancers. And I think that's often, actually, there's another book I would recommend. It's one by Atul Gayandi. And the name escapes me now, but one of his books was effectively, if we could apply what we knew already in medicine now, equally to people all over the world to the best of our current standards, we'd already be going a long way to improving our outcomes. I'm afraid I don't think having everyone being cured sort of without side effects, as it were, with a one-size-fits-all approach is anywhere on the horizon.
I think what I would say is that I've been doing this for quite a while now, and if I compare outcomes at the start of when I entered pathology to now, there are tumours and stages of tumour spread that at the start of my career would have been regarded as palliative, which are now being cured. And I think melanoma is a good example here. So at the start of my career, stage 4 melanoma, where you have metastases, was universally, relatively rapidly fatal. Whereas now, in a subset of patients with advanced disease in whom we find mutations that we have a particular drug that targets, people are surviving for quite considerable times with metastatic melanoma. And again, with children's cancer, there are children with tumours at an advanced stage that at the start, when I first went into paediatric histopathology, would not have survived, who are now long-term survivors. So even within one's career, one can see this massive shift. And it's not just cancer that's happened in. So, the situation in HIV has been an absolute game changer from when I started my career in medicine through to now, with the use of PrEP, really good drugs, and this whole you is you concept. So we are getting there, but I agree with Tolly that it's going to be a case of chipping away, and there won't be a magic bullet that cures everyone with no side effects, because that's the other arm as well, as trying to make treatment as least disruptive to people as possible. Okay. So I'm not sure. I think what we'll do now is move on to the Q&A part of the session for admissions. So I will get Oscar to unmute and just introduce himself first, and then Atul. So if you've got any questions that you would like to ask about admissions, so application forms, personal statements, interviews, then you can pop those into the Q&A. Oscar.
Hi, I'm Oscar. currently recovering from a nasty flu, so I might sound a bit croaky. Third year at Homerton, I'm currently intercalating in neuroscience this year. And I will try my best to answer people's questions, but honestly, I feel like they change the admissions process every year. And I mean, when they changed it from the UK CAT to the UCAT, I had enough of a trauma with that. So, but yeah, that's me.
Atul?
Yeah, hi, I'm Atul, and I'm a second year medical student at Homerton. And next year, I would like to intercalate in a similar thing to Oscar's, a neuroscience, but with maybe more of a behavioral aspect to it.
Okay, so any questions about admissions, application forms, interviews, personal statements? Pop them in the Q&A. While we're waiting to see if there are any, I'm just going to ask you for your, in fact, we've got one already. So how did you prepare for interviews? So that's a good one. And what types of questions could you be asked? So should we take the first part first? So when you were preparing for your interview, Oscar, how did you do it? And having been through it, would you have done anything differently?
I think, I mean, specifically for Cambridge interviews, I mean, interviews are fairly heterogeneous. You have the MMIs of the world, you have the more sort of halfway house panel interviews, and you also have the very hardcore academic ones. I think a key starting point with preparing for interviews is identifying what type of interview you've got. I've said this before, but at my King's London interview, it was very clinically skewed, and there was not much science. And then about 2 weeks later, I had my Cambridge interview, which was hardcore science and various aspects of me getting skewered about various things I didn't know much about. I think my sixth form, I was very lucky that they had some experience in giving practice Oxford interviews. But in many cases, I don't think you actually need to have a dedicated, like, let's have a practice Cambridge interview or a practice Oxford interview. I think you can get away with, if there's someone in your biology or chemistry department who's fairly into research and has, like, I mean, again, I had the privilege of having many well-qualified teachers in my sixth form in the biology department. You could quite easily just happily sit down with them and just have a chat about some biology thing you found on the internet. And to be honest, that is fairly close to what a supervision / what an interview is like at Cambridge. It's, you talk about a thing at length for 30 minutes in an interview or an hour in a supervision, and you sort of see where you can go with that and see what you can apply it to and see how it's relevant to things you already know. So I think that's a good way to start. You don't need to have a set defined 1 week before your interview, sit down and do a practice interview. I think just having conversations about random things you find interesting with teachers that know things is quite a useful starting point.
Great, thank you. And same question to you, Atul. So how did you prepare and what would you do differently having been through the process?
Yeah, so definitely I agree with Oscar, and probably the most important thing is being well informed about how your interview is going to go. Like, just knowing if it's going to be roughly like an academic interview or a clinical interview sort of thing. And definitely, it doesn't even have to be like with another person. It could just be to a mirror. Just like being able to verbally explain the scientific concepts like in a concise way that I don't feel like we get a lot of practice with that until like we get to uni and we do supervisions and stuff. But, and just having a little bit of practice, maybe just explaining like a chapter from like the biology textbook, just like, okay, how would I phrase this to be able to clearly communicate it, like I would in like a answer, like to a mark scheme, and just being able to like systematically explain the points from like most important to least important. And definitely being, and for a similar thing, for certain questions about like why you want to study medicine or why Cambridge, just having a brief outline of like the main points you want to talk about, just so you don't miss anything and you seem and when you do communicate that answer, it sounds like you've actually had some thought about it instead of just making something up on the spot.
So the second part of your, so I'll just give some comments about preparing for interview. And I actually may have not introduced myself, having introduced everyone else. So I'm Liz Hook, I'm Director of Studies for Clinical Medicine at Homerton. So I do interview for Homerton, but I don't think I interviewed either Atul or Oscar, which means that they can say what they like about the interviews, therefore. So how do I recommend that people prepare for it? I think it's always really helpful, firstly, to remind yourself what you wrote on your personal statement, because again, that's very much fair game. So if you've written something on there and we ask you about it, that's us trying to actually be nice and give you a gentle way in. So if you can't remember what you wrote on your personal statement, then obviously that's backfired slightly. The other thing I think it's always really, really helpful to do is to keep your eyes on what's going on in the news. The people who set and think of interview questions are influenced by what they sort of hear around them. So, you know, if I'm sat down trying to decide what my question will be for this year and something's being quite current, then there is a chance that my thinking may evolve around that. So, you know, have a look at the themes that are coming through in the popular news and then go away and look at the scientific background to them. So if they've published something about the latest breakthrough in cancer, read the article in whatever daily paper you read, and then go away and look at the science behind it. So what is the publication that is the basis of this headline that I'm seeing in the papers now? Then I think just making sure that you've covered the areas that people tell you commonly come up. So just make sure you've done a bit of reading about them. I think Atul's suggestion about making sure that you have got used to doing your working out loud. So I think that's the biggest thing that I see when I interview is people who try and do all the working in their head and just tell me when they've reached the answer. And if that answer is not correct, that is quite difficult to then unpick. But if you're doing your working out loud, just as if you were doing a maths question, again, that's really useful, because if I see that perhaps you're going down a slightly blind alley, I can bring you back to the question. But it's actually quite an unusual thing, particularly on the biological side of science, to do this talking and thinking out loud. And again, you could practice this with with family members, with friends, with colleagues in your lesson. Just take a topic each and have a go at explaining it to each other in a stepwise sort of way. In terms of the types of question, I think there's a very broad range of things that can be asked. As indicated, some interviews will very much focus on what you've perhaps read about clinical medicine, about clinical practice, ethical issues, etc. Whereas some interviews, most noteworthy, certainly the ones that we do in Cambridge, have a very scientific focus where we will take what you've been studying at school, but we will expand on it. So we will be looking to ask you things that you might have some familiarity with the general concept, but what we're particularly interested in is where you go when we try and take you out of the area where you've directly learned about it. So we want to see how you handle material that you're not so familiar with, using the snippets of information that you do know. Okay, this is probably one for me. How important are extracurriculars such as music, grades, D of E, etc. when it comes to universities comparing different applicants? For example, would achieving grade 8 in piano hold more weight than just playing piano as a hobby? What I would say from my perspective is that no, it wouldn't, because what I'm interested in is seeing the range of things that you are interested in. And I'm very conscious when I read personal statements that the opportunities that people may have had access to are very, very variable. What I'm interested in is that you have something that you are interested in and you can articulate to me how and why you're interested in it. If you do things like, for example, captain the rugby team, rather than just telling me that you're captain of the rugby team, why does that help? What do you gain from being captain of the rugby team in terms of sort of leadership skills, organisation, etc.? But also, what do you give to being captain of the rugby team? So rather than just writing captain rugby team, tell me a bit about it. And I think this is also verging into answering another very, very good question that popped up on my list.
I just had a point about the music side of things, just because I'm quite like involved in that side in uni. Essentially, like I can't speak from an admissions point of view, but generally, like in terms of music and performing and stuff, it's very much just something to show that you have something else that you can lean back on and like stress relieve with, like just because there is going to be inevitably times when you are getting too stressed with work and you need something else to work with. And definitely music is a great way to do that. And the in terms of like opportunities at Cambridge with music, it's there's I think only the very top university band actually has a grade requirement where you need to have a certain grade to join. But everyone else, like all the other university level, like music groups, they typically have auditions, but then literally all the other music groups that aren't really just a university level have no grade requirement at all. And like you can just join and just have fun, like alongside doing a fairly difficult degree.
I think sport is very similar. So there will be people who put on their form that they've done this at, you know, junior, international or county level, and that's great. But there'll be people who write things like, you know, I'm really interested in running. I do park run every Saturday morning. Again, it's just telling me that you take your time and you do something outside work. And again, with sport, when you get to Cambridge, there'll usually be a first team for things in the college that's really competitive. And then there'll usually be other teams where perhaps actually the biggest criterion is just turning up and having fun. So I think, you know, really what's of more importance is the fact that you put it down there, and you put it down there in such a way that personalizes it to you. And I'm going to jump down the list because I think that ties into another question down here, which is how do you make your personal statement sound unique to you and academic without making it sound boring and monotone? So my first advice on this is that you write it, so it is your voice. It's very apparent when you read a lot of personal statements over time, and you can see the voice changing in them. So if you write parts of it and someone then writes something out for you and you put it in, you can tell that when you read it. And I think, you know, it's very great to take advice from people, but just make sure that you keep it in your own words. And the way I think you avoid it sounding boring and monotone is that you tell us what the things you're putting on there mean to you. So rather than just a list of I do this, I've achieved this, how does that relate A to you and B to medicine? So what are the things, you know, list your work experience. We can talk about work experience in a minute if anyone wants to talk about that. But rather than just listing it, you know, what about that work experience has really informed the decision that medicine was right for you? What have you gained from it? Why did that experience really chime with you? And as we know, you know, similarly for volunteering or helping, because we know work experience is quite challenging to get at the moment. Again, what has it meant to you to do that? What have you gained from doing it? Okay, I think this is one for you too. If you were asked why Cambridge, how different would your answer be now compared to when you applied? That's an excellent question.
Oh, did someone have to ask this question whilst my director of studies is in the call? Did someone have to ask that?
I can stick my fingers in my ear if you want.
I'm just glad she's not my director of studies just yet. So
she is currently your supervisor, is she not?
For like, I think 2 more supervisions. So
you'll be needing Liz as the exams come up. Don't
yeah, probably
count that. I think I originally applied to Cambridge partly because of the scientific rigor. And I think that is actually still the same now. I mean, for some people, I understand basically running down like a list of go away, LinkedIn. I understand for some people going down a list of 20 research papers on something in your third year is their idea of personal hell. For me, it's not. I enjoy quite how scientifically based the course is, and I still do. I don't think one can ever be fully prepared for how hardcore scientific it is until you're here, because you'll hear from lots of people, oh yeah, it's really hardcore scientific, and you don't believe them until it's very hardcore scientific, and you're having to learn things that you're not entirely sure how it relates to clinical practice. I also, yeah, I think, what else did I go to Cambridge, honestly?
Did you find the college experience similar or different to how you imagined it would be?
I found it better than I expected it to be, because I think, without naming any particular colleges, but I think some colleges sometimes get a bit of a reputation for being a bit cliquey and a bit isolationist, and I haven't actually found that since being. I mean, it's fantastic to be able to go back to your own little community at the end of the day, but it's not anywhere near as sort of segregated as I think some people on Reddit and other sites will make you think it is. It's very much just, there are very much advantages to it, and it's not just about where you go back at the end of every day or after your 4 lectures or whatever. But it's not like you don't make friends at other colleges. It's just, it's nice to have a sense of belonging, but it's not restrictive, I think is.
Yeah. The only thing I can't entirely relate to is because our first year was in isolation. So like,
unfortunately had a very, very different experience.
Like,
first
so
year.
yeah, it was very much, like, to be fair, we got along really well. That was like a big plus. Like, I think because Julie put all of the 6 medics and the 3 vets together in one household, it could have gone one of 2 ways, I think.
I don't think you had a choice really than to others to be friends.
I just explained that when ATOL started, we had to group individuals by subject household. So normally we'd be quite mixed in the first year, and we'd make sure that people were the people doing a good range of other subjects. But because we had to put people in groups, we put people together in subject groups, which we'd not done before. So I think the overall experience was
it was definitely different, but the definitely just the fact that from what I've heard from our current freshers and from Oscar's year group, and even us now, just like expanding beyond Homerton quite a lot. It very much is that the colleges give you a place to go back to that will, like, you'll always be fine like being there, but also like the other colleges are just open, like you can just go to them. They're not like gonna just turn you away, and like they're not like, it's not as like a hard line, oh, this is a different college, you're not allowed anywhere in there, sort of thing.
Unless you're a kid, maybe, but anyway, that's a different.
Yeah, like, I mean, did you not say we're not naming specific colleges?
Yeah, I did say that. I think that, also with that in mind, I think with ATOL being not stuck with medics, but being grouped with medics in first year, I think also thankfully, because my first year was mostly normal up until about this time 2 years ago, I made a lot of friends in other subjects, and it's very, very, I think being at Cambridge is very good for broadening your horizons in that capacity, because my college wife, because college marriages are a thing, and I suppose if we've got 10 minutes, we can explain them at some point. My college wife is a lawyer, and that was extremely interesting when I was doing the medical ethics and sort of law aspects in first and second year, to be able to talk to a lawyer and have her views on it. And it's really good to be able to have these sorts of conversations with people who have a very different perspective or have had very different life experience at that point. So you do get a very well-rounded view of various big topics, not just within medicine, but overall. I think is also a very good thing.
Yeah, because like definitely just being like, we did actually like communicate with other people outside our household. Like, it wasn't that much of an isolation last year. I don't know, Liz, you might want to cover your ears for that a little bit. Like, just but yeah, like, definitely being at Cambridge, it's everyone doing their subject like is already so like invested within their subject that like talking to them about that, like about why they're interested in what their interests are, is just so like interesting in that way, just because like every single person has a completely different reason for like why they're interested in their subject, but just because each subject is enormous, like I don't think a single one of the medics like in our year has the same interest generally, like and just because medicine is a massive field, like you can have your own interests and then also like talk to other people about theirs, and it's not like you're not really overlapping a lot essentially.
I think certainly my perspective coming at this from a faculty angle and sitting down with various students at various time points to talk about their experiences is that whilst we are very clear that the Cambridge course is a very, very scientific course, I think there are some people who are surprised at the fact that there is minimal patient contact in the first 2 years. And I think if you perhaps haven't fully appreciated that is the case, it becomes a little bit more difficult to keep along with the course. We'll answer the top 2 questions first, and then we will get Oscar to clarify exactly what he means by a college wife. So what resources did you use to prepare for your UCAT and BMAT, guys?
I mean, BMAT wise, at the very least, they do provide a nice little syllabus for the section 2. I think, I mean, section 1, they changed in recent years, I believe. I can't remember exactly how, because I haven't helped with people applying to Cambridge for a good 18 months now, so I don't know if it's changed further. But I remember with section 1, it's very much, I think, doing as many practice questions as possible, because some of those questions are a bit nasty, and a little bit, if you had like 2 hours to look at the question, of course you get the right answer, but you haven't got 2 hours. So I think it's being able to get used to digesting quite a lot of information in a short period of time and then being able to use it to answer the question, which is similar with the UCAT as well, because there's a lot of overlap in the skills that both of those assess. Practice is very important. Not too much practice, because I remember talking to some people when I was going through it and saying that when they were practicing for the UCAT for too long, they actually found that their performance started going off a cliff after about 4 or 5 weeks, because they'd almost oversaturated themselves with it. So they found that the peak of their performance came about a month after they were started properly preparing for it, and then found that actually they were sort of running around in circles after that point. And I think with BMAT, with the section 2, and I mean the section 3, yeah, and section 3 is separate, but section 2, I think very much just look at the syllabus content for it. The biology and chemistry bits of it, assuming you're doing biology and chemistry, the concepts are not hard. It's just sometimes they will try and trip you up on a question, which is the point of it. So the concepts themselves aren't very difficult. And I think for people who haven't done physics, i.e. if you were me 3 years ago, if you haven't done physics A-level, you may need some reminders of how physics actually works, and especially the electricity bits, because otherwise you'll stare at a circuit and go, what is going on here? And the essays, I think essays come down to, I mean, it depends on how important you find the BMAT essay. Different unis holds different weights to it. But I think being able to answer the question with as best examples as you can, as concisely as you can. I did English literature at A-level, and let me tell you that English literature essays and BMAT essays are not the same beast whatsoever, especially because you've only got one side of A4 for the BMAT essay, or I don't know how they've been doing it in online situations, but it's you really have to pick the absolute best points and best evidence to make your points, because you have only got one side of A4, and even if you think you have small handwriting, it's not that small. You are going to struggle to fit all of it into one side of A4. And yeah, I think that's 2 things there. That's all. Have anything to add?
Yeah, so definitely I'd say 4 weeks is probably like the maximum you should be like studying at a time for like, just because you will start burning out at some point and you don't want that to be before your exam essentially. With the BMAT, there's lots of past papers online. Just going through them and just doing the questions is probably like good enough to do well on that. Just with the section 2, the science stuff, depending on what like exam board you're doing for biology, make sure you specifically go over every point that they have in the syllabus and make sure you've done everything. Just because some of the topics might be in one board but not another, and typically the biology marks on the BMAT tend to be the ones that you either know it or you don't. And if you don't, there's literally no way of figuring it out, just like from like looking at it longer. So just making sure you're familiar with all the points just means that like you can just see the question and do it, and then move on to a more difficult question that takes a bit more time.
I'd agree with the biology comment, because my biology exam boards did not do anything on kidneys or diabetes or blood glucose homeostasis. So imagine my shock when I started opening these papers and it actually asked me to remember things like insulin and glucagon. So that's
I don't think they brought up insulin and glucagon until like the very end of like 6.2 again. So they
didn't turn up in mine at all. So
yeah, like especially because a lot of these topics you might have come across in GCSE, but then it's not in the first year of A level, it's in the second year, and you might not cover that like by the time you need to know it for your BMAT exam. So like you just need to make sure you go over the specification, make sure you know every point, and just make sure that like you're not missing anything that is like going to lose you easy marks essentially.
And I think, as the same for any exam that you ever do, knowing the timings that you have for questions in that individual exam and practicing those timings individualized to you if you get allowances, very, very important. Okay, another good question here. What work experience would you suggest during a gap year? I'm actually going to split that in two and talk about work experience and gap years. I'll do the gap year first. So it really doesn't matter what you do in the gap year, whether it's a year for traveling, whether it's a year for working. I think it's just it's an individual choice and circumstances thing. Work experience I will talk about. So we know, everyone who interviews and looks at application forms for medicine knows that routinely work experience is obviously very dependent on the opportunities that are available to you anyway. But at the moment, for the last couple of years, it has been very, very challenging to get into a hospital and other healthcare environments to gain the sort of work experience that we used to see people doing. So we know that has been difficult. I will couple that by saying that I do not think you need to go out and sign up to do these very, very expensive courses that offer you whatever. I think it's perfectly possible to demonstrate on your form, talking about things like this. So, you've turned up on a Monday evening in your own time, showing independence and being proactive about arranging to attend this. That's the sort of thing I'm looking for. So you've attended talks about various aspects of medicine. You might have taken part in some of the free online work experience. So Brighton and Sussex, for instance, do some free online work experience. There's a virtual GP work experience available as well. And then you combine that with something like, for example, volunteering at a local care home, or last year, in fact, we had a lot of people who'd volunteered to help at the various vaccination hubs, and were talking about the experience they'd had of talking to people who were coming in for their vaccines who might have been really nervous about it, and how they helped those people, for example. So all of these things, just think, how does this potentially relate to demonstrating that I understand what a career in medicine entails, and that I'm demonstrating that I have found opportunities to work with people, communicate with people, and support people. So I think, anything along those lines. Places are gradually opening up to work experience again. So it's worth just making sure you've got it in touch with your local hospital to get on their mailing list for when they restart their work experience. And the other thing I would recommend, particularly in terms of finding free opportunities, is that the grad entry medical courses have a very set amount of experience that you need to gain before you apply. And in order to facilitate that happening, they offer a list on their websites of various opportunities that exist. So if you go onto one of the grad entry medical schools and just have a look at what they're listing as potential free work experience opportunities, take advantage of those. But I reiterate, you don't need to go on one of these very, very expensive courses. Okay, so finally, Oscar.
I had a
go on,
before Oscar, like I did have a point about the work experience side of it. Definitely with the COVID vaccination, I feel like that allows you to like have like essentially a very broad range of age groups that you're seeing like that care for, because definitely like something that might obviously I can't speak from the admissions perspective, but like the showing that you have a fairly realistic idea of how medicine is different between age groups, like can maybe like show that okay, you actually understand there are different aspects to medicine other than just straightforward healthcare. Because like when I was in my personal statement, I included I did like a comparative aspect where I talked about some work experience I had in a neonatal ward and the different like aspects in that type of care, and compared it to my experience in a care home and volunteering there. So just being able to show that yes, you understand like all the how different factors such as age affect your care essentially in the NHS, is probably a good thing to know as well.
Great, thank you. So Oscar, your moment in the limelight. Someone has asked, what is a college wife? It's a very Cambridge thing, I'm afraid, everyone.
This is a general Oxbridge thing as well. I think also Durham has stolen this as well. So college families are a sort of niche thing that, in order to help you sort of transition into being at Oxbridge, you are put into a quote-unquote college family where you have a college dad and a college mum, or two college dads, or three college dads, or two college mums, a college dad, and a college duck or something. Basically, there's no real particular thing. And so they are kind of there to help you settle in, and depending on how interested they are in maintaining a college family, you may speak to them once in the first week and then never again, or you may actually be friends with them for the rest of the time that they're all there. They're usually in the year above you. So your college father and your college mother are college married, and obviously, therefore, their spouse would be their college husband or their college wife. So I do have college children. Have I spoken to them for 18 months? Perhaps not. But I mean, I did make effort. I do want to state that I made a lot of effort with my college children. They were not receptive to said effort. I can't help it if they chose to be emancipated. But that's
is it subject related?
Oh no. Well, it depends who's in charge of setting up college families that year, actually, because who comes up?
Ours was entirely different.
Yeah. Whoever comes up with college families is someone on the college union. So each college has a union of students. Someone is in charge of doing it every year. So some years they will do it more based on subjects, and some years they'll do it more based on common interests. It does mean that I ended up with a mathematician and a lawyer as my college children, with whom I have no real massive overlap in interests, I will admit.
And do you get in contact with them before they come up to Cambridge?
That depends on how quickly the people in charge of dealing with the college families actually get on top of it.
I think the original model, and the model when it's being organised in a timely way, is that the second or third years who are your college parents get in touch with you a few weeks before you come up. The idea is that therefore there's a friendly face, so that when you arrive in college, there's someone who comes to find you. So many decades ago, when I came up to Cambridge, my college mum came and knocked on the door of my room later that afternoon to sort of say, look, let me come and show you around. And they then took you to the bar. I was at a college that didn't do Sunday food in college, so they then sort of found somewhere to take you out to eat on the Sunday. Homerton College does food on Sundays, so that's not an issue at Homerton, but at the college I was at, there was no catering on the Sunday, so they had to take you somewhere. So that is college families in Cambridge, Oxford, and I believe therefore Durham as well. Okay, I think we've answered everything that came up in the Q&A, and we have hit bang on 8 o'clock, which is perfect timing. So thank all of you so much for coming and asking some really fantastic and very thought-provoking questions this evening. Thank you so much, Tolly, for your talk, which was absolutely excellent. And thank you, Atul and Oscar, for very honestly sharing your experiences. Thank you. Goodbye.